So this the same what we discussed so far. We had a femoral access and a balloon tip to TPI because expected to burr for a long time, and we thought we would require a step-up burr approach. So we entered with the 8 French long sheath. Plan was to use a rotational atherectomy, step-up burr approach. If you see carefully in the pre-image, it was a slow flow, and PLV was filling retrograde from the other side. So we thought we use a smaller balloon to get the flow better. Then we go with a bigger balloon. So we start. The plan was to start with the 1.25. It may differ. Might have used 1.5, but it's a long segment. Quickly get the flow, then go up with the 1.5, and do an IVUS imaging. Initially, we were not planning to do an IVUS image pre, but whatever we had small previous experience, IVUS catheter would not go through that. And then if needed, based on the IVUS imaging, we go up with a 2 millimeter burr and using scoring burn preparation, again reassess with IVUS, stenting, and IVUS guided optimization. So that was the plan. So this is how we started with. And it was very difficult to get the wire down. We tried microcatheter, it wouldn't go through, and we just directly wired with the rotaflappy wire, 125 burr. Once we did 125, the flow improved a bit, and we did a 1.5 next, and after 1.5, we could pass IVUS catheter. Maybe if Dr. Gary or somebody wants to comment on this IVUS images.
Well, obviously a lot of circumferential calcium. There's a calcified nodule that's probably eruptive. Again, more calcium, circumferential. You see some breaks in the calcium, like right there. And another eruptive calcified nodule.
We had 3 or 4
three
of
them.
Yeah.
They tend to cluster in some arteries.
Yeah, exactly. It is. And we had 4 of them actually. And what do you think? Was it what we had is the right approach? So we still felt it was a large protruding residual calcium. So, and the wire bias appeared to be favorable because most of the places it is sitting over that protruding calcium. And again, it was calcium all around. So we thought it is safe to go up with the next size burr. What is your comment on that?
Oh, for sure. Not sure exactly how much more you're going to accomplish, but in terms of safety, absolutely, not even a question.
So the aim was to just save off as much as possible, and we didn't have an orbital atherectomy here, so we went ahead because we had an 8 French sheath. It was so we ended with a 2 millimeter burr, and after 2, this is an IVUS image. So far, no balloon dilatation. And Gary, could you comment on this?
Sure. I mean, you see circumferential calcium. Here's the most distal calcified nodule at around 9 o'clock. Again, circumferential calcium. Starting to see little breaks in the calcium, but another nodule. So that's number 2.
Yeah. And the lumen is reasonably improved, right?
Looks a little bigger.
Yeah. And that's it. And we didn't have 225 to go ahead with. Right. So we went ahead with a 3 balloon, NC balloon dilated distally and proximally, and a 3.5 scoring balloon preparation. So after that, it looked reasonably okay angiographically. And we confirmed in 2 views the balloon was reasonable. I can't say that 1:1 expansion, but reasonably well expanded. And we didn't have, but if you see the reference vessel size was 3.5, so we didn't want to go above that. And we didn't have IVL those days. It was done in 2017, this case. And just used a 3.5 38 stent distally and a 3.5 32 proximally. Again, reasonably expanded. And post-dilated with a 3.5 NC balloon. And this is what we got after doing that. Still, you can just see that it was a part of the stent is eccentrically expanded, and there was some malapposition you can see in the second frame. And again, redilated, and this is what we end up with. Our reference was 7.2, ended up with a 6.5 minimal lumen area inside the stent, and we thought we just stop with this. We didn't proceed beyond that. And we had similar patients, but we got at least 50% of the patients coming back with the problem again. Fortunately, this guy is somewhat doing well for the 4 years. So this is what the final result, what we got.
Yeah, for some reason, we're seeing these more and more.
Yeah. And they come back. We expected him to come back, but fortunately, he's doing okay. Because as you said, and we have seen patients coming back, but you see image and see this protruding nodule again inside your stent.
Right.
So that is what we get. And we stopped with it, and we felt it is a reasonable result, what we started with.
No, I would agree.
Thank you.
You will always see some malapose struts, by
Yeah,
the way.
that
100% of the time when you have a calcified lesion, the stent will never be fully opposed. And it's of no importance, but just don't expect it.
Yeah. And maybe this is one situation. Try to get make that protruding nodule is at an eccentric calcium, so we get at least a D-shaped expansion of the stent. And we had a patient recently that not adequate preparation ended up with a bean-shaped stent, not a D-shaped stent. So that is what the situation we try to avoid by using step-up approach. Thank you.